faithfully conveying value and interpreting great books from around the world.
Hello, this is Sally's Book Talk.
Today, the book we'll interpret for you is Broken Trust. In the previous episode we discussed the 1994 plague outbreak in India and the 1995 Ebola outbreak in Zaire. Due to neglect of public health, both countries lacked essential infrastructure, failing to respond timely to outbreaks and even turning healthcare facilities into catalysts for spreading diseases. The emergence of modern public health systems is inseparable from the Industrial Revolution. Large numbers of laborers moved from rural to urban areas, crowding into cramped spaces without sewage or waste disposal facilities. Once infectious diseases emerged, the consequences were unimaginable. Therefore, in the 19th century, modern public health systems were established in countries like the UK and US, with public health departments organizing waste and sewage disposal, providing safe drinking water and clean living environments. New research from effectively reducing the spread of infectious diseases. Since the 19th century, developments in bacteriology, immunology, and modern pharmacology have not only helped us understand the causes of many diseases, but also enabled active control of epidemics like plague, cholera, and tuberculosis, achieving one public health success after another. However, the author points out that even in countries or regions with relatively sound public health systems, collapse can occur due to social and economic pressures. In this book, the author examines what can lead to the failure of public health systems, drawing from the histories of the Soviet Union and the United States. He also discusses the challenges facing global public health in the book. In the next episode, I'll interpret the main content of this part for you in two sections. First, what causes public health systems to fail? Second, what threats global health might face in the 21st century. Fortunately, in the first part, we'll look at what factors can cause public health systems to fail. The author focuses on the problems in the public health system after the dissolution of the Soviet Union in this region, noting that during the Soviet era, the system achieved significant results. In 1917, before the October Revolution, the average life expectancy for men in this region was only 38 years. And by 1970, the average life expectancy for Soviet men reached 65 years, and for women, it rose from 43 to 74 years. Meanwhile, infant mortality rates dropped from 25% to 70%. However, after the dissolution of the Soviet Union in 1991, a series of epidemics broke out in the region. 200,000 people were infected with diphtheria, ultimately causing 5,000 deaths. Polio struck Azerbaijan in 1991 and Uzbekistan in 1993, respectively. In 1995, the Ukrainian government shut down for over a week due to influenza. In 1996, 20,000 people were infected with typhoid in Tajikistan, and other public health issues, like malnutrition, began to emerge. By 1993, the average life expectancy for Russian men had fallen from 65 years in 1970 to 58 years. By 1998, this number dropped further to 57 years. There were many causes for this situation. For instance, a direct reason for the high incidence of infectious diseases was low vaccine coverage. Oh my God. In the 1980s, vaccine coverage in the Soviet Union was very low. The author believes that, on one hand, this was due to ideological issues. Much Western science was banned, and Soviet scientists knew nothing about the most basic principles of vaccinology. On the other hand, a mysterious immunological theory emerged in the region, suggesting that vaccine-induced reactions could endanger vulnerable children. Any sick child, including those with a cold, children with white blood cell counts 5% below normal, and those with a family medical history, could not receive vaccines. Of course, this situation isn't unique to the Soviet Union. Previously on Sally's Book Talk, we discussed a book called The Age of Anti-Intellectualism. It mentioned that in the 1990s, many American parents, influenced by anti-intellectualism, believed vaccinating children against measles and mumps could cause autism. So, although scientific research has never found a definitive link between the two. Back to the Soviet Union. According to WHO data, in some regions of the Soviet Union, during the 1980s, child immunization rates dropped to levels comparable to sub-Saharan African countries. And so, by 1991, only 60% of children under 5 in Russia were vaccinated with the trivalent diphtheria, pertussis, and tetanus vaccine. Experts believe preventing infectious diseases requires achieving 95% vaccine coverage. In this context, the resurgence of diphtheria in the Soviet Union during the 1990s was hardly surprising. Diphtheria typically infects the mucous membranes of a person's nose, mouth, and throat. It forms a white membrane at the back of the throat, causing difficulty swallowing, vomiting, and breathing problems. In severe cases, the diphtheria bacterium can enter the brain, heart, or nervous system with a mortality rate of up to 10%. In 1993 and 1994, former Soviet countries reported 15,000 and 39,000 diphtheria cases, respectively, accounting for 60 to 70% of global cases. In 1994, Tajikistan had 31.8 diphtheria cases per 100,000 people. In Russia, this number was 26.6 cases per 100,000 people, 30 times the incidence rate in the United States. The WHO considered this the greatest public health threat in Europe since World War II. Diphtheria was brought back by soldiers from the Afghan battlefield. In the 1980s, Afghanistan experienced a diphtheria epidemic. Those Soviet soldiers infected either hadn't been vaccinated or had received vaccines made in the 1950s with insufficient diphtheria toxin. That Western researchers in the 1990s discovered that in Soviet regions, not only was vaccine stock severely inadequate, but Soviet counterparts were completely unaware of the need to keep vaccines refrigerated during storage and transportation. And additionally, millions of children received adult doses of vaccines, which should not have happened. Children who received adult doses had a diphtheria incidence rate 5 times higher than those who received appropriate doses. The failure of the Soviets' original sanitary epidemiological station system also contributed to this. This system covered almost all villages in the Soviet Union. The stations were responsible for identifying disease carriers, isolating them from the community until they recovered or died. And people also had to regularly go to the stations for vaccinations. At its peak, 280 million Soviet people queued for vaccines in a single month. However, with the dissolution of the Soviet Union, this model became unsustainable. Moreover, economic recession led to an increase in local public health issues. After the dissolution of the Soviet Union, Soviet industry declined as well. Millions of people lost their jobs. According to UNICEF data, about 25% of people lived in extreme poverty within 18 months after the Soviet dissolution. By 1996, the average monthly wage for Russians who still had jobs was only $153, 10% lower than in 1992. In 1998, the Russian stock market crashed. The ruble plummeted. Severe inflation followed. Food prices soared. Beef costs increased 85% in a single day, while milk costs surged 60%. By late 1998, a University of North Carolina study showed 100% of Russian children suffered from iron deficiency. Malnutrition was widespread among pregnant women and children. Iron deficiency. And nothing weakens immune systems and overall health more effectively than malnutrition. Well, the CDC and WHO found severe micronutrient deficiencies, iodine, potassium, calcium, iron, in the Soviet region, leading to reduced IQ, anemia, stunted growth, and developmental defects. Social and economic collapse also caused psychological breakdowns, triggering alcoholism. This problem long existed in the Soviet Union, but after its dissolution, per capita alcohol consumption increased sixfold and alcohol-related mortality rates skyrocketed. In 1995, nearly 500 per 100,000 people in the region died from alcohol poisoning. That same year, only 77 per 100,000 Americans died from alcohol poisoning. Psychologist Anna Trinchava believes this relates to people's identity and self-perception. Previously, individualism wasn't encouraged and personal worth wasn't supported. After the Soviet collapse, these people fell into confusion, believing they had nothing but alcohol. Public health issues from economic recession weren't unique to the Soviet Union. In the 1970s, the U.S. economy faced double-digit inflation, negative production growth, and persistently high unemployment. Against this backdrop, public health failed to fulfill many core responsibilities. For example, in 1970, U.S. measles cases exceeded 47,000, twice the rate during the 1963 mass vaccination rollout, indicating declining vaccination rates. By 1971, the U.S. recorded 75,000 measles cases, 1.6 times the previous year. In 1981, President Reagan proposed tax cuts and federal budget reductions to address U.S. economic stagflation. Now, this bill requires cutting the federal budget by $130.05 over approximately 3 years. The budget for the Department of Health and Human Services was cut by 25%. Changes in tax laws and reductions in social welfare benefits have widened the wealth gap in the United States. Political economist James Savage from the University of California believes this bill increased America's overall poverty rate by 2% in 1982. The author points out that when a society's wealth gap widens, public health often deteriorates, with the poorest being the most affected. In the book, the author gives an example. During these budget cuts, the Indian Health Service was one of the hardest hit agencies. Established in 1955, this agency primarily serves Native Americans. Since Columbus discovered the New World, these indigenous peoples have had the worst health in North America, being highly susceptible to tuberculosis, diabetes, heart disease, and alcoholism. Their economic situation was also poor, with unemployment reaching 40% in the 1980s. 1/3 of Native American families lived below the poverty line. Within 5 years of its establishment, the Indian Health Service reduced infant mortality among Native Americans by 25% and tuberculosis mortality by 50%.
Public health funding cuts immediately caused doctor shortages at the Indian Health Service and led to continuous narrowing of its service coverage.
By 1987, only those living on Indian reservations or members of federally recognized tribes could receive the agency's services. This meant half of the 2 million Native Americans lost access to the agency's assistance. By 1988, when Reagan left office, 1/3 of Native Americans died by age 45. Previously, their likelihood of dying from tuberculosis was 400% higher than other Americans, and diabetes mortality risk was 155% higher. And the author notes public health's effectiveness is proven by negative outcomes. In optimal conditions, nothing happens. Safe water and food, clean air, no epidemics, vaccinated children. But precisely because of this, when budget crises arise, politicians often feel it's completely fine to cut public health funding. The author also notes that even during epidemics like AIDS, Ebola, or plague, those in power often remain unaffected since they're typically wealthier than ordinary people and can access better health care.
Meanwhile, as public health budgets were cut, U.S. spending on medical treatment continued to soar.
After World War II, public attention shifted toward clinical medicine for cancer and cardiovascular diseases, while interest in public health issues declined. In 1992, less than 1% of all personal and public health expenditures in the U.S. went directly to public health, with 99% allocated to medical treatment. Americans under 65, comparative, age-based costs. Americans under 65 spent an average of $2,349 annually on healthcare, while those 65 and older spent over $9,000. Moreover, healthcare costs kept rising while the number of uninsured people increased. By 1997, about 43.4 million Americans lacked health insurance, over 15% of the population, mostly African Americans, Latinos, and poor whites. This placed them in danger. A long-term study from 1971 to 1987 found that lacking insurance directly caused higher mortality rates as the uninsured had less access to medical resources and lower quality care. All right, that concludes part one: low vaccine coverage, rising uninsured rates, unstable socioeconomic conditions, and public health funding cuts all can cripple public health systems. In the 21st century, public health still faces numerous threats and challenges. In part two, we'll focus on three challenges, starting with bacterial antibiotic resistance. In 1995, Dr. Jarvis from the CDC stated, "Over the past decade, antibiotic resistance has increased in every bacterial species we track." Dr. Jarvis believed this might be America's top public health threat.
According to a 1998 Institute of Medicine report on antibiotic resistance, resistance is broadening and bacteria are developing it faster.
Take Staphylococcus aureus, for instance. Its infections can cause various purulent inflammations, and in severe cases may lead to sepsis. Around 1950, all Staphylococcus infections could be cured with penicillin-based drugs, but by 1998, 90% had become resistant to penicillin. Additionally, 20% of Staphylococcus strains are resistant to another antibiotic, methicillin. Methicillin-resistant Staphylococcus aureus, MRSA, can only be treated with expensive vancomycin. This not only increased Staphylococcus mortality from 8 to 17%, but also raised the average treatment cost per case from $27,700 to $31,700. And
worse yet, vancomycin-resistant enterococci, VRE, might share their resistance genes with streptococcus or staphylococcus, creating a highly infectious superbug.
this report from the Institute of Medicine states that antibiotic-resistant bacteria cause at least $4 to $5 billion in losses annually in the U.S., and this phenomenon is global. In the 1990s, surveillance systems by the University of Iowa in Europe, Canada, and Latin America all found rising proportions of resistant microorganisms. The WHO's global surveillance network also observed the same trend. Moreover, WHO has monitored that DNA rings carrying resistance genes are sharing antibiotic resistance among bacteria and even species, mainly due to misuse or inappropriate use of antibiotics. For example, in the late 1990s, multi-drug-resistant tuberculosis, MDR-TB, spread through Russia's prison system and gradually nationwide. After 1991, Russia's crime rate surged, prisons became overcrowded, and tuberculosis broke out there. I wonder, however, due to limited treatment options in prisons, doctors often gave inmates only 1 or 2 antibiotics at a time, instead of the 4 or 5 recommended by WHO. And these medications were often whatever was available. At that time, an expert from Russia's Ministry of Health said that among infected individuals released after serving sentences, about 80% carried resistant strains, and half died from TB-related symptoms within months. Having covered the issue of resistance, let's now discuss the second challenge facing global public health: bioterrorism. On March 20th, 1995, the Japanese cult Aum Shinrikyo released deadly sarin gas on Tokyo subway trains during morning rush hour. Sarin gas is a nerve-paralyzing agent that can enter the body through inhalation, skin contact, or eye membranes, causing dizziness, muscle spasms, and breathing difficulties, ultimately causing death. A total of 5,510 people were injured in this attack, with about 100 hospitalized and 13 fatalities. Afterward, Japanese police discovered this gas attack was merely a rehearsal. Aum Shinrikyo had stockpiled enough sarin to potentially kill 4.2 million people. Even before this, Aum Shinrikyo had conducted at least 2 prior gas attacks, including one in June 1994. They dispersed sarin gas in a residential area of Matsumoto City, Nagano Prefecture, resulting in 7 deaths and 660 injuries. These events prove that biological weapon capability isn't limited to governments. Ungoverned groups or even individuals can acquire microorganisms capable of massive public disaster. What? The author notes biological weapons differ from nuclear arms. Any pharmaceutical factory or medical lab can produce them. Moreover, they can be disseminated using ordinary agricultural equipment, like pesticide sprayers or crop dusters. In the Tokyo sarin attack, terrorists simply punctured gas-filled plastic bags. Additionally, obtaining materials for bioweapons isn't particularly difficult. According to the World Directory of Culture Collections, 453 microbial repositories exist globally. 54 cell transport anthrax, 64 cell typhoid-causing microbes. Additionally, 34 cell botulinum bacteria. Botulinum toxin is among nature's most potent poisons. It attacks the nervous system, causing dizziness, breathing issues, and muscle weakness. In 1994, Germany's Federal Intelligence Service found Iraq-sourced bioweapon materials mainly from Western Europe. For example, 39 tons of bacterial growth medium bought from a Unilever subsidiary, with only half verifiably used in labs. In the mid-1980s, Iraq also purchased anthrax seed samples from an institution in Maryland, USA, with this procurement even approved by the U.S. Department of Commerce. The book notes that some microbial repositories even conduct transactions online. No scientific credentials needed, just a credit card number to buy microorganisms. And online, there are numerous books teaching how to produce anthrax or use biotoxins for assassinations. In 1995, a White House report predicted that on a windless day, terrorists dispersing 100 kilograms of biological agents over Washington, D.C. could kill millions. A real accident in the Soviet Union might show how severe bioterror attacks could be. In April 1979, an anthrax experiment at a bioweapons lab outside Yekaterinburg failed catastrophically, releasing anthrax spores. Typically, humans exposed to anthrax develop symptoms within 1 to 6 days. South of the accident site, about 77 residents soon showed classic anthrax symptoms: muscle pain, fatigue, fever, dry cough, with 83%, 66 people, becoming critically ill. Some developed brain or nervous system infections causing meningitis and seizures. Others had lung infections leading to pulmonary hemorrhage and gradual suffocation. The Soviet Ministry of Defense distributed preventive medications like antibiotics and vaccines to locals. But as winds blew southward, more people fell ill, some developing symptoms up to 6 weeks post-exposure. In just the town nearest the lab, approximately 1,000 people died. In 1997, the U.S. Los Alamos National Laboratory performed lung tissue biopsies on victims. Results revealed the lab had released at least 4 distinct strains. This mixture resisted existing vaccines and antibiotics. Thus, the Soviet Defense Ministry's post-accident actions proved futile. A Harvard study found the accident involved under 1 gram of anthrax spores, a quantity easily evading airport security or police checks. More critically, anthrax spores can remain airborne for extended periods. The U.S. Army Medical Research Institute of Infectious Diseases conducted studies exposing monkeys to low-dose anthrax. One monkey became ill 59 days after exposure. Dr. Henderson, an American public health expert, believes even minuscule, nearly undetectable amounts of anthrax spores could profoundly impact public health in cities across North America, Japan, or Europe. And so far, we've covered the challenges bacterial antibiotic resistance and bioterrorism pose to public health. In the book's conclusion, the author mentions a third challenge: population aging. As people age, immune systems erode. White blood cells and lymphatic tissues renew slower and become less diverse. Thus, the elderly get sick more easily than the young and suffer more autoimmune disorders where the immune system attacks healthy cells. For instance, elderly individuals with thyroid issues face higher risks of immune failure against microbial invasions. That's why influenza and pneumonia can be deadly for seniors, whereas younger people might just feel unwell for a few days. Vaccinologists believe herd immunity requires a critical threshold, say 90% community vaccination, to protect individuals. As the proportion of immunocompromised individuals rises, it may pose major public health challenges. To reduce infectious disease threats, we must enhance microbial surveillance and support more scientific research, such as studying the elderly's vaccine responses or developing specialized immunization strategies for them. That concludes the main content of Broken Trust Part 2. What are your thoughts on the challenges facing public health? Feel free to share your comments below. The author argues that with globalization, public health is no longer confined to single nations or regions. Governments, pharmaceutical companies, labs, and public health forces worldwide must mobilize to address new challenges. In this global village, each member's health is interconnected with all others. All right, that wraps up our interpretation of Broken Trust Part 2. Reading notes are below the audio. See you next time.